Welcome to Breaking Barriers. You know your path. We know the obstacles. And we can teach you how to tear them down. And now your host, CEO and founder of Adapting Social, John Vigero.
Guys, welcome back to Breaking Barriers. Today is an epic day. We got Dr. Vernon with us here today. Doctor, thank you for being with us.
Thank you.
With CMC, Comprehensive Medical Care.
What's your name again?
My name? Who gives a fuck, honestly? I don't matter, you matter.
No, the truth is, I'm not great with names. You can ask.
Yeah. So you're Dr. V, you just call me John V.
John V?
Yeah.
Johnny V?
Yeah, exactly.
Not from Jersey City.
Not from Jersey City.
I know
from
a lot
Hoboken.
of Johnny V's in Jersey City.
Do you?
Yeah, well, that's like Schwartz in Miami. You know?
Exactly. So, guys, the interesting part about this genius here today, I'll call him, I can't even go through all the list of your things. Obviously, when you go through all of your certs and things you have, he's certified DO, DC, CAQ, PM, and then also RMSK. So for the people out there who have no idea what these certs are, obviously, can you give us a little bit of a background on this?
Sure. I made most of them up, but they sound good.
They do sound fancy as hell.
I trained at UMDNJ, which is now New Jersey Med or Rutgers Med. It was New Jersey Med 100 years ago. Then it was University of Medicine and Dentistry.
Right.
Which actually have a funny story about when I told my father I was going. I don't know if my wife was sitting over there and remembers. And I said I was going to UMDNJ. He said, so you're going to be a dentist? I said, no, it has a dental school. He said, no, so you're going to be a dentist. By about the fifth time, I said, yeah, I'm going to be a dentist. But it was the state school.
That's what they're most known for?
And then they changed the name. It goes by governors. You know, this governor, that governor, and then they'll change it. Then they change it back to New Jersey Med, Robert Wood.
Right.
Then they change. Now they call it Rutgers Med. So I believe. So got me.
Right.
There are some offshoots that are still RWJ. But
right.
That's it. How much more you want to know about that?
That's kind of
boring.
So that's good. But now, one thing that I want to ask, so before we go into all the nitty-gritty of pain and obviously, your non-invasive, non-surgical stuff, is, so a lot of doctors, right, because we have a lot of people that listen in that are, aspiring doctors, want to get in the field, but medical school is fucking hard, right?
Yeah.
You have a lot of certs, so I'm just curious, how did you get through all that shit?
Well, fortunately, I liked academics.
You did?
Yeah. Actually, when I was finishing my first residency, my wife caught me with an application to, I guess it was it Rutgers Law School? She said, absolutely not. We're broke.
Not happening.
No. So I did outpatient medicine for a while. My practice was restricted to adult medicine. Well, kids are Martians, so I don't really, and built up a big practice. Got semi-bored with it, not in the sense of helping people. I helped an awful lot of people over my day, but then I decided to train more, and then I did interventional pain, which it was 7,500 hours, which was standard fellowship would be about 4,000, but
right.
I went the old-fashioned way. It was called clinical pathway.
Right.
So I had to get my own cases, produce it, do that, and then take the board certification, which I did. And then toward the end of that, I really took a liking to ultrasound because just like you would ultrasound the baby, I ultrasound joints, tendons, muscles, ligaments, and it's a very point of service care, and there's a lot of times I can treat stuff very quickly. So I started to get, I didn't plan on going through the board certification, but I figured, well, I'm in, I might as well, and I kept studying, and I would bring my machine home, and my family would run away from me because I said,
everybody was your guinea pigs.
Especially my kids, Daddy just needs a half hour, and and they would say, no, please, no. My wife was pretty good about it. She would just fall asleep. All right, so then I went through all the training there. I did the certification course through Thomas Jefferson University, Philadelphia.
That's where our sister went.
Did she? My condolences. And but there's the head of radiology there, Dr. Nazarian, has a very, very well-known name in the field, particularly for starting intervention under ultrasound. even though he's a radiologist or map reader.
Right.
And for the most part, he's got a good name. His training program was great, and then extended it to the AIUM, which is American Institute of Ultrasound Medicine. Sat for the board, did the practical, got my cert in that. And being trained in interventional pain, which is you use X-ray. I don't know if you're familiar with fluoroscopy. It's kind of like a continuous X-ray if I'm doing a spine procedure. But a lot of pain docs don't do joint procedures. So, and I think that the training was lax on that. So then I would go out to Colorado and train out there. I would go out about every week per month. And I got advanced training not only in spine, but I started doing advanced training in interventional orthopedics for shoulder, knee, and hip, and ankle, for all joints.
Right.
And that was also based towards regenerative medicine and trying to spare people surgery. So if they come in with a bad knee, and you're going to hear this, anybody that's had a bad knee, osteoarthritis or anything like that, they'll say, well, I went to my orthopedic surgeon, and he said that I don't need a knee replacement right now.
Right.
Gives them a cortisone shot. Maybe they'll do viscosupplementation, which they would be better off doing without the shot. And you don't need it now, but you'll need it in 2 years.
Right.
Because that's what they do. And we have enough data to prove that the cortisone injections actually speed up the process. So in a way, I think it's a way of perpetuating your own business. So, but there's a lot. Right, there are a lot of knees that can be saved, as well as hips, rotator cuff tears, all the things that I do. So as I advanced my training, I started to develop skills to use more interventional techniques, way outside the box of what you would say interventional pain.
Right.
And initially, until I got more the certification in advanced joint, I would run into interference, and occasionally still do. But if I can stick a needle within a millimeter of your spinal cord in your neck, putting a scope in a big joint like that, you basically would have to be an idiot.
Right.
Plus, the use of ultrasound and fluoroscopy, or continuous X-ray. I mean, if you miss, you probably shouldn't have one in your hand to begin with.
Correct.
But I've helped a lot of orthopedists out when they're looking at joints too, because there's a lot of stuff they don't pay attention. If you go in and you say you think your muffler's doing something, and you go to Midas, well, you're getting a new muffler.
and new tires.
Right. Now, I'm not against surgery, and I don't want to give that impression. I've sent many people for surgery when they need it. I think that there's too many.
Right.
And I think that really a lot of joints can be saved if they would at least try.
Right.
Not only that, listen, let's face it, and this is probably, maybe I should say it, I'm a little heavy, let's say, and I should be, thinner, but my patients that have come in, they have these BMIs over 40. Number one, they're not even surgical candidates because they're too high risk. Even the Academy of Orthopedic Surgery will not let you do it. Some are even moving down to 35 and 36.
Really?
Right. So, but I apply the same principles if I'm treating a hip or a knee.
Right. Depending
on the staging, if I won't treat it and put stem cell and do some other things unless they get under a BMI of 40, because it depends on the joint, but for the most part, it's a chance. There's no guarantee.
Right.
And so exercise, physical therapy, prehab, as we like to call it at CCMC, is that we prehab them, and if they'll stay with the program, but it doesn't happen yesterday.
Right.
If they've got a BMI of 45 or something, it's going to take 4 or 5 months.
Right.
So there are things I can do to keep them comfortable and try to keep them functional. It is a paradox because these people can't walk as well, so they can't lose weight. At least that's the excuse I use. But but I've got bad knees and shoulders, and so I know what they're feeling.
Right.
But that's their part. If they can't do that, I won't even do the stem cell. I would say you're better off getting onto a good diet plan, getting diet, and by the time you're going to lose, if they're going to lose, they're going to need a new hip or a new knee.
Right.
But we could save them early on. The problem is medicine for years probably. Am I talking too much? You want me to stop?
No, keep going.
For years,
A lot of education.
For years has been talking about preventative medicine.
Mm-hmm.
That doesn't just stop with treating blood pressure.
Right.
Okay, or treating coronary disease or anything like that. It starts with body habitus. The biggest epidemic, obviously, the preponderance of people that I'll see in the practice with bad hip, shoulder, and knee,
Right.
are going to be morbidly obese.
Mm-hmm.
If they would start earlier and start to get this, their staging of knees, and to keep it sort of relatively simple, there's 4 to 5 different stagings of a joint, for
Right.
instance. Well, because everybody's got to have their name on it, but it really is the same thing. I use Kelligran, I use what's called the Womack. All
Right.
And for brevity's sake, I would say 1 through 4, 4 being the worst. If we can catch these people between stage 2 and 3, or 1 and 2, we've got a really good chance of them never having a new knee. Hips are very difficult, the blood supply is poor, so
Right.
if we can catch them early on, we can treat them and help them. There's the problem now is a lot of people are running around. You will see signs even in this area, and I see signs. I actually reported one to the Attorney General in Florida. I had a patient when I left my South Jersey office
Right.
and came up to CCMC that went to Florida to get stem cell. And when I he didn't get any better. So when I questioned him, now he had what's called a KL4 knee, which is like your femur or this bone up here by the top of your knee is almost touching your ankle. So there was not much ankle left, and a bad shoulder. Now his shoulder definitely could have been fixed. His knee, probably. I wouldn't. There are other procedures you can do to maybe, and I would be very low on
Right. Big maybe.
preserving. They charged him $15,000 for stem cell, so I ended up getting the operative report. And once I got the operative report, I saw they drew 150 cc's of bone marrow from one site, which is the second I looked at the op report, I knew was garbage. And then we're charging him $680 a month for cryo freeze of his stem cell, which there was probably very little stem cell. The normal way to do it is to take about 20 cc's in 3 sites.
Right.
To maximize your stem cell. 150 cc's, all you have is immature blood.
Right.
Yeah, what we call metamyelocytes. So plus $15,000. And he was waiting, and he was paying for the cryo freeze on it, which was totally stupid.
Right.
So, and that was, I believe, I don't want to cast aspersions, but I think I remember the name. I don't have to say the name, but it was in Florida. There was 20 or 30 places across the country, and they got closed.
Because of that.
Well,
and malpractice.
I
probably
sent
like that.
it out to a mentor of mine.
Yeah.
Had him look over the operative report. And he almost came through the Zoom on me. He said, "Are you kidding?" So then the wife was with this patient. She said, "Can I use his cryotherapy? His frozen." I said, "No, it's garbage. Basically, you've been paying for a year for that for nothing." So you have
$680 for a year.
plus the first
plus the
15,000,
15K.
and then worst of all, and I would caution anybody whether they're getting just a standard even cortisone shot, which I say that with a little bit of pain.
Yep.
Cortisone is okay sometimes.
Yep. Don't overabuse it probably.
But certainly if they're getting viscosupplementation injections into their knee, okay, I use it. It's only approved for knee, but I will put it in a shoulder or a hip because
Right.
they're all synovial joints. If they're not putting it in with imaging, you go in with a rotator cuff tear and they want to do PRP.
Yeah.
If they're not imaging it and the guy says, they know where to go.
Right.
Run away. Run away. You should check whether he has interventional experience.
Right.
How he's going to. Those are questions they don't ask.
Yes. So wait, quick pause. So everybody listening in on that, I want you to seriously take a listen there. So many times we're led by different professionals in the medical space, and a lot of people just take the advice, right? and do this.
Yeah,
and then,
because maybe their friend got,
Right.
But you don't know whether it was their knee, what stage the knee is. That's why I went through that.
Yeah.
So everybody's a little different. People heal differently. If they have
Right.
comorbidities, diabetes, things like that, you know right off the bat if they're going to get better, whether it's PRP, stem cell,
Right.
that it's going to probably take more. If anybody sets you up a plan and says, well, it's going to take 20 of these and 4 of those, get out of the office. Now, right now, we do have a protocol for knees where they get viscosupplementation, they get 3 PRP injections, high concentrate PRP injections, 1 week apart.
Right.
Because that's the protocol established by the American Association of Orthopedic Sports Medicine.
Correct.
And it's a great study.
Right.
Okay.
So, but for people that are listening to PRP and saying, what in God's name does that even mean?
Okay. All right. PRP, the best part about PRP, and this is where the division between that and cortisone comes in.
Right.
Cortisone, you come in with your shoulder giving you a lot of pain, I take a look, say, well, you've got some tendinosis, bursitis, or whatever. And I inject it. Within 72 hours, your pain is going to go away, and then your function or movement will improve. But it's a Band-Aid.
And it's not going to last.
Right, and you stand the chance that if you do have a tendon issue or a joint issue, you stand the chance of extending the injury, making it worse.
Wow.
Especially if you've got an underlying tear.
So is that due to I get a shot, I'm a football player, get a shot in my arm, now I feel better, so I'm using full range of motion again, and I'm just hurting it.
Right, I mean,
because it's numbed or whatever the hell's going on.
Right, I mean, none of them have joint replacements.
Right.
Right, I've treated a number of pro football players.
Right.
And one presently still, which I could probably mention, he's a friend of mine, Brian Boulding, he's still on the NFL channel. And the reviews are old because I treated him and I treated Mike Shad and some others, and they all did very well.
Right.
And avoided knee replacements. So, but we got on them early. They were diligent. Now, granted, they're freaks. I mean, they're still in great condition.
Right. They're dealing with big animals on the field.
Right.
But so there's a huge controversial like when people talk about stem cell and regen medicine, there's so many different angles, so many different, there's so many different there's red tape everywhere. So for people out there that are saying, what the hell is stem cell? Never heard of it, don't know what it is. Like, why do you recommend it so much, and why is it a big
I don't recommend it so much. I recommend that you...
Well, dependently, obviously.
Okay, you have to think of it as a surgery.
Okay.
Number one. Any surgeon looks at the statistics. Okay.
Let's use an example, though. Let's go.
That's what I'm going to give you right now.
Okay.
It's called patient stratification.
Okay.
You stratify your patient, and with all those things that I mentioned, high BMI,
Yep.
comorbidities, including diabetes, things that are going to prevent them from healing. Every time you put one of those on the scale,
Right.
the chances of them improving are less.
Got it.
Okay? Plus the stage of the joint.
Right.
Okay, the type of injury, the type of problem. Those are all things that have to be measured against. Now, at times, there are people that are morbidly obese like that with comorbidities that can't get surgery. They're too high risk.
Right.
They're healing nightmares and infection nightmares.
Right.
So those are people that there's times we can do some things for.
Right.
But one thing no one will ever accuse me of is making a promise. But getting to your question, that's only part of it. I see a lot of people in the area, in this area, in Jersey, and you'll see signs that they say they're doing stem cell. I had a very recent case. A young man was a fireman. They promised him he was getting stem cell in his low back. No one even took an X-ray.
Wow.
Okay. And he had what's called a spondylolisthesis, which was a slippage of the vertebra. So it sets all the physics off in his back, and he's a fireman.
Right. So you need that.
No, that is a surgical case. That is not a stem cell case. He has an unstable spine, but no one took an X-ray, no one did an MRI.
Right.
Okay. I'm not sure they even examined him. And then to boot, which was the worst part, when he said he got stem cell, I asked him, where did they do it? Because typically I'm going to do something like that in the surgical center because I have to harvest the stem cell first from your pelvis. And that requires me drilling a few holes in the bone and so I put people to sleep for 5 minutes. That's what I would want.
Right.
And they did none of that. They used what's called amnio, which is amniotic fluid harvested and cleaned up from a lab, and it's certified that it's virus-free, it's tested for all the viruses. The problem is it's not stem cell, it's dead growth factors.
Okay.
And I could explain growth factors to you, but the best way to describe it is the reason why guys take anabolic steroids is because they increase their growth factors, like TNF, IGF-1, things like that, right? So all those, when they raise those, they get into an anabolic state. Well, these are dead growth factors from basically chorion or amniotic fluid.
Got it.
There is a way to use them. The first one that came out was many years ago. I used it. It was by Applied Biologics, but I used it on an Achilles tendon, which is what it was really meant for at the time, activated with PRP. And it did happen to work in that patient, and they did well. For the most part, that people are lying. If they're not taking bone marrow, that's not truly stem cell. Now, you can use fat, which are, they're not true what we call stem cell. They're called periocytes, but they differentiate. In other words, they have the capacity, whatever, I'm not going to use the word milieu, but whatever environment you stick them into, they'll differentiate into those cells.
Got it.
I have done some fat transpositions with it, but you still have to process it. I've seen other people where they've just taken the fat out and just stuffed it in there. I mix it. I actually call it a Fatty Mary because we'll mix it and process it. Okay, get most of the periocytes out. And then mix it with high concentrate PRP. Hence a Fatty Mary. And that has worked for me. But there's no one. Everything's going to work on one thing.
So speaking of that, though, obviously, so there's a couple things I want to jump into. But one thing, though, so at CMC, can you talk a little bit about, obviously, everything that CMC does pain management-wise and, again, how it's like a one-stop solution for people that have that need pain management?
Okay. One of the things that encourage people to do is if they have a back or joint injury of any kind, whether it's shoulder, knee, neck, hip, whatever they've done, is to go online. They don't need to believe me. That's the first thing, because that's exactly what I tell my patients. Go online, and the government has great data on multidisciplinary approach. Multidisciplinary approach, and this is where the workers' comp people are stupid. They send it to Joe Blow doctor. He's a family doctor, or I had one that was a pediatrician. Like, if they're not putting their thumb in their mouth yet, fine. But getting hurt, having that kind of injury, multidisciplinary facilities have a much better track record of returning people to work, shortening their injury phase, and getting them active quicker and return to what we say return to play, or return to normal activities of daily living and become more functional. And that's hard data. Now, some of the orthopods will jump up and down and say, well means nothing to me. I mean, well means that the statistics are there. Certainly they'll quote them if they're negative. If that makes sense.
People run wild when that, So, I saw you went to Monmouth University.
Yeah, we can go through that. I thought I'll give you this one here.
Well, no, I'm going to get there.
Okay, go ahead.
But the reason why we have a commonality there, because
you went to Monmouth?
No, my first job was at Monmouth.
What were you doing there?
So my buddy's mom was the manager of the kitchen. Aramark used to be the vendor. So
the food wasn't bad there.
Listen, when I was there, I was chopping up deli like you never saw before. The sandwiches I would make there were the best.
Yeah.
How did you like going to Monmouth?
How bad could Monmouth be? West End.
Yeah. Well, you're coming from Jersey City, so you obviously didn't.
Anywhere was good.
You stayed though, right?
But anywhere was good.
Right.
Yes.
Yeah.
Anywhere was good.
Now, all right. So let's talk. So going into these, right? I love that you wrote this out for me, but I can't read your handwriting here.
All right.
So
I went to UMD. I actually went to University of New England for my first year of medical school. And having a wife and 2 kids and going to university, I would drive home literally every Friday from Maine.
Really?
Yeah.
Are you kidding?
Yeah, that helps the marriage along. And but she was really good. My wife was great, and anybody that could put up with me was, because she could see I'm a day at the beach. And then transferred. I put in a couple applications here and there, and I remember I put it into Temple, and I got an interview, but they wanted me to start like from the first year. I asked them if they were insane. Like, why would I do that again?
Right.
And then I got into UMD and J.
Okay. And they respected those credits or whatever, so they transferred?
Well, yeah, I had a pretty good average when I transferred. But that's why I don't understand the start over thing.
Yeah.
Yeah. I mean, does that make any sense?
Mm. But a lot of students have to do it.
There's a lot of doctors that should.
Right. So one of the things that I saw though too is now when you are not treating patients, what is Dr. Vernon doing for fun?
Who gave him that question? I am just for fun. I talked to Chris. I talked to who's my chief operating officer and run CCMC, and we talk about mostly how things could be better. Those are the things I enjoy.
Right.
I one time talked to a psychologist who was, actually I would say a psychiatrist who was a friend of mine.
Yeah.
And I remember, because how old was Jake when I was a resident? Like young, right? 5, and my daughter was an animal, and he said, "You okay?" I saw him at breakfast. I said, "Yeah." He goes, "Because you don't usually sit with me." And I said, "Well, you're a psychiatric resident. Nobody would sit you."
No one has to be.
Right. And he said, "What's going on?" I said, "Oh, nothing. It's like it's here, 36 hours on, 12 off.
Right.
Go home, and like the kids are and this and that." And he said, "Do you hate them?" I said, "Well, yeah, like sometimes." He goes, "You don't want to hurt them or anything?" I went, "Of course not." And he goes, he goes, "Perfectly normal."
Yeah.
So I went, "Oh, okay."
So everything's all good.
Right. So what do I like to do? I actually really love my work. I mean, I'd rather be at a seminar than on the beach.
Really?
As long as it's a cadaver seminar and I can drill something or do something.
Right. So wait, so online, right? So we did some research on you online, right? We dug up that you enjoy chasing around your bulldogs.
I love my bulldogs.
Yeah. So what's their names?
Toots and Lloyd. Did anybody see Entourage?
Of course.
Okay, remember Lloyd?
Yeah.
That's who Lloyd's named after.
I love that.
Lloyd. Yeah. So that's who I named Lloyd after, and I love them. They're, first of all, they're like thermometers, because I don't like the sun and the heat.
Yeah.
Not just never did, even when I was thin.
Yeah.
And they'll stick their head out the door and they'll look. They're not going out.
Then know.
I'm going.
So they're your gauge. I love that. So they go up to the door, boom, not going out.
They're very calming to me, and I like anything that doesn't talk and ask me for money.
There we go. Love that. So as we come to an end here, so 2 things. So what advice would you give to an early phase medical student that is trying to push their way through medical school and keep going?
What advice would I give to them? I would say that if they had an internship to do a rotating internship. So number 1, that you learn medicine, so you rotate through every service and you're the king, especially at night by yourself, of every service, whether it's oncology, transplant medicine, whatever it might be, so you learn what sick looks like. Because I can assure you, I have a great story for that if you wanted, but I really do.
Yeah.
I think my first night of internship, I walked in with my pressed jacket on, my shirt and tie, believe it or not. Yes, Chris, I wore a shirt and tie. back then.
He was a suit guy.
And
Suit guy.
and my jacket with my name on it and all this. And that was at Our Lady of Lourdes in Camden.
Yeah.
And make a long story short, as soon as I switched beepers, I took at 7, and I was going 7 to 7 to 7 for the next 36 hours.
Right.
7:01, that was my first call.
Right.
And it was 5 West, and I didn't know where 5 West was, but I went there.
Right.
Found my way there, and it was the transplant floor. Now I was hoping for something like a chest pain or shortness of breath, something that is fairly routine to take care of. And it's a younger woman, about 38, 39 years old, laying in bed with literally her husband and 2 little kids there. I think I was too nervous to look at how old they were. And she was starting to acutely reject her. She had a kidney pancreatic transplant.
Wow.
Yeah, my first call. Well, I'm
the first one's always got to be the memories, right?
The black cloud. Make a long story short, I still to this day hope, I looked at the husband, I said, she'll be okay. And she was not making urine, which is a problem when they have a new kidney. And I still hope that my stethoscope was in my ears when I was listening. I don't even remember what I was listening to.
Right.
And as Chris will testify to, that I tend to sweat when I get nervous.
Yeah. Shit,
Okay.
I think we all do, right?
Right. I mean,
But maybe
I mean
a little extra.
Really sweat.
Yeah.
We call it diaphoresis medically. Okay.
Okay.
All right. And I said, okay, she'll be okay. And the transplant nursing staff was there, and I walked out. And I think you'll remember her name, darling. Her name was Pam. And she was a transplant nurse. And I had transplant medicine. I did it at Temple.
Yeah.
But, you're a dumb medical student. The next day you're a doctor. And I walked out into the hallway, and there was the moment of truth. I said, you might as well call the janitor. I could hurt her.
Right.
And then I looked at her and I said, I think I'm going to faint. I felt like I was going to faint.
Right.
So first thing he did is sit me down and give me orange juice and stuff.
Yeah, chill out.
All right. And then I called the transplant team, who happened to be in Damascus. So I used a satellite phone.
Right.
Called, and I knew we could give her steroids, so I gave her 80 milligrams of steroid, and the surgeon is screaming at me through the phone, 500, you idiot. And I was just screaming his orders out like a mental patient.
Right.
Yeah. So the two things to learn out of that is, number one, you rotate through everything like I did, so you do learn when people are sick. You learn an awful lot of medicine. The only way to learn it is on your own at night, where you have to sign your name. And July 1st is a bad place to be if you're sick in a teaching hospital because you're getting an intern.
Yeah.
But usually you have a resident backup.
Right. That is such good advice. I think a lot of people get too focused on a thing early on and then carry it out.
Most of those don't go through that, if you've ever, statistically.
Yeah.
7 out of 10, if they go in thinking, oh, I want to be a radiologist,
Right.
they end up with
Changing.
something else, right? Unless you're, still never understood the male gynecology thing, but.
Well, Dr. Vernon, I'm so grateful for you to be on our podcast today.
Thanks for having me.
I appreciate your time. And obviously, you're repping CMC, right?
Yes. Comprehensive Medical in Monroe and Edison. We have 2 locations. Maybe more coming to an area near you. You don't remember the Crazy Eddie commercials, do you?
Oh, of course I do.
Well, there's no specials. We take good care of our patients, and we tell them the truth. And we have a great rehab staff and prehab staff.
Prehab, right?
Yes. So if it's an athletic injury, work injury, auto accident, or basically weekend athlete.
Right. Right. And including, obviously,
I noticed your left knee, by the way. I think it was when I was talking.
When you were walking, yes.
Was it your left knee?
It was my left knee.
Do you have a problem with that?
I don't have pain in it, but when I was...
You will.
Yeah, in the future, I'm sure I will. But when my mom said that when I was a kid, I had the, what do you call it? My feet were like this.
Yeah,
So growing up...
Wasn't rickets, right? No, I'm kidding. We don't get rickets here anymore.
Yeah. And for anybody that wants to follow Dr. V and his journey, and also obviously know more about CMC, you can find them on Instagram, all major social media platforms. comprehensive medical care, and as well as obviously the website, thecmc.com. And again, Dr. V, thank you so much.
You're welcome.